Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Recovering from a medical condition or trauma doesn't stop after the visit to the emergency room. Once there's a diagnosis and treatment begins, the process of rehabilitation then starts to take place. There's an integral team of physicians, nurses, and staff that focus on occupational, physical, and speech rehabilitation, and each has a unique purpose to help the patient recover. During this next hour, we have experts answering your questions about how to get back to living your life after a traumatic neurological event. We've got a great team here, and as if you know, this is a live program, so if you have some questions of your own you want to ask us this evening, give us a call at 881-0013. Also, we are streaming live on Facebook, so if you are a Facebook user or not around a TV, you are welcome to ask your questions on Facebook, and those will also come our way. Just enter KCOS TV in your search bar. This evening's program is underwritten by Las Palmas del Sol Healthcare, and we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the medical students for us. This evening we have, oh my gosh, I had it on here, Aaron Pines and Heather Jones, and they are veterans, and they really know. There they are. Hi, guys. I love how they smile and wave on cue. It's fantastic. So again, thanks to the Texas Tech Paul F. Foster School of Medicine for providing the students, and as always, the El Paso County Medical Society for bringing the show to you for over 22 years. I'm Catherine Berg, and you're watching The El Paso Physician. Thanks again for joining us. How do you get back to living your life after you've had a major neurological event? We're going to talk a lot about that this evening. With us, we have Dr. Zoraya Paria, like tortilla. I like that very much. She's neurorehabilitation specialist. She's the only one in our region. We also have Carol Cuss. Sorry, Carol's on the end. We have Jacqueline Rincon, who's a physical therapist. And then we have Carol Cuss, who is a rehabilitation nurse. So thank you so much for being here. And I kind of described what your titles are and what you do, but I'd love for you, for the audience, so they kind of know which questions to go to. Dr. Tortilla, so I'm going to call you Dr. Tortilla now.
Feel free to.
Tortilla. I understand that as the only neurohabilitation specialist in the region, can you explain what that means and what's the integral part of what you play all day, every day in our region?
Yes, so first off, I'm a rehabilitation specialist, and I'm glad that I have the opportunity because it is a specialty that is very often underutilized, undermined, if we may, and it's not well understood what the scope of our specialty is. And so you have an idea, in El Paso, which is a population about 700,000.
Right.
We have about 7 rehabilitation doctors. So there's a lot of necessity for our services, but basically a rehabilitation doctor specializes in mitigating or even reverting the impairments and disabilities that come after any condition, disease or trauma, injuries.
Reverting is a great word.
Yes.
Yes, trying to get that back to that position.
So, but our focus is bringing a patient to function in any way it could be.
Okay.
So we do this obviously utilizing medicine, but the rehabilitation specialist coordinates the therapy services. So between the two things, we try to bring this patient back to a level of function, whatever it will be.
Right.
And it doesn't stop at the hospital, but we also look into all the resources in the community to then bring this patient back to function in the society.
Nicely said, and I love how this is a team approach, and we're going to get to what Jacqueline and what Carol do in a moment as well. And as we are talking this evening, think of just some case studies that you know that this requires a small bit of rehabilitation, and then those that really have some extended multi-year type of issues. So Jacqueline, as a physical therapist in what you specialize in now, what is it that you do all day, every day?
So I specifically work in the inpatient rehab portion of the hospital. So we are there to give patients at least 3 hours of therapy a day, at least 5 out of the 7 days a week. Specifically for physical therapy, I'm assessing their functional ability. So that may include watching them get in and out of bed, seeing how they get from a bed to a chair. I'm also seeing their locomotion, so that may be walking or it may be needing to use a wheelchair, as well as possibly negotiating steps. So watching that functional mobility, I'm also assessing their strength, their balance, their endurance, so I can see pretty much where they're at right now and what we need to work on to get them back possibly to a previous level of function, or modifying for a new lifestyle for now.
Nicely said. I like the way you use locomotion too. That's a good word. So Carol, you are a physical therapy nurse. In your day, in differentiating from physical therapy, how does your function play in this role as well?
Well, we do carry over a lot of what therapy does. We try to encourage, when therapy ends with the therapist, we try to carry over therapy in helping the patient become as independent as possible while they're on the unit, whether that be walking them to the restroom or allowing them to do things for themselves, like undressing for bed and grooming and all that activities that they do.
Okay. And so on that note, let's talk about, so PMR, and I know we talked about this right before the show began, so physical medicine rehabilitation, that's the specialty here. And some of the typical conditions, let's just say that and I don't want to get into percentages and you don't have to give us numbers or anything like that, but in general, on an average year, what are the majority of situations that you see coming through your door?
Well, because we specialize in, we are based in a trauma center. So evidently we are going to see a lot of trauma patients, traumatic brain injuries, spinal cord injuries. We see a good number of strokes, intracranial bleeds. And then we see surgical patients abroad, multiple surgeries. We see patients with pneumonias, heart attacks, and even we get a small number of patients that, for example, have failure to thrive and they're just very debilitated. So even though there's a criteria for that admission, but we see a vast variety of cases.
Okay. For you, what do you think, what is the most difficult to treat? And let's go to trauma first, because that's the one that's so unexpected, right? You don't know what's going to walk through the door, if there's been a car crash or somebody fell off a roof, etc. So let's first take trauma. And what is and this is a brain injury, what are some of the very difficult issues that you have seen?
Well, actually, as you have said before, I'm a neuro rehabilitation specialist, so I have a subspecialty within the specialty.
Right.
So evidently my passion is trauma, traumatic brain injuries, and even within that, patients nearly comatose.
Oh my goodness.
So you can get that specialist.
Right,
but basically, the patients, can be as severe.
So say if they're comatose and it was caused by an injury, and is there a certain amount of days or weeks that comatose becomes more dangerous going forward? Is there a certain point where rehabilitation's happening within the body, but then you're looking at the brain, because that again is your specialty?
Correct.
So number of days, maybe let's look at a time frame of what might be.
Well, unfortunately, we're going to be limited in the amount of days that we're going to be working with that patient. So we have to be actually quite aggressive, even if they're not participating with us, like following commands. You will imagine somebody with a severe traumatic brain injury, they might not even be able to comprehend what you're asking them, but we take them from that level, again, either using medications, certain types of stimulation, even getting them out of bed, sitting. That even begins the process of rehabilitation. So we can have patients for a month, 2 months. That's actually lofty these days, unfortunately, because
Yeah,
of
it is.
how
That's true.
healthcare behaves in the hospital.
Yeah.
I have the fortune of being director of a post-acute neurorehabilitation program here.
Okay, good.
So I can even follow those patients for many months, and I can see them progressing
Right.
from the level they were at the hospital and then sending them home at a completely different level. So I have that luxury and blessing. They probably won't, because again, we're catching the patient very fresh,
Right.
trying to do the best we can to then move them to either another level of care or even home.
Right. And Jackie, Jacqueline. Sorry.
You
Do you
can
ever
call
go
me
by
Jackie.
Jackie?
Yes,
Sorry.
I
It
go
just
by
kind of came
Jackie.
out of my mouth. My best friend in high school was Jackie. But so let's take now that you are providing stimulation. You are now looking at physical therapy. You're trying to get commands to be obeyed. Just open your eyes, speak. Can you say la 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 for me? Explain to us some of the issues that you see when you have someone that's severely injured. And then in a moment, I'd like to talk about strokes, because that is something that I feel like everyone has a relation to. Not everyone, thankfully, has a relation to something traumatic, but strokes and other issues along that line. But say there's something traumatic, and now what are the simulations that you provide for the patient to try to get them to respond?
So like Dr. Perio was saying, so we do get those patients, and they may not be cognitively intact, they're not following commands, but we still need to get them moving. So sometimes it's a matter of us just directing them simple commands, or even just physically helping them to the edge of the bed, and physically helping them to a chair, and working on basically starting, I guess, a little bit earlier. Maybe we'll do some range of motion with their lower extremities, upper extremities, just to get them more alert. We like to see basically if they respond to any type of stimulation. Maybe rubbing sternal rub, just to have them be more alert. But also when they do become more alert, sometimes overstimulation can confuse them and overwhelm them. So we also adapt our therapy techniques to that situation by maybe dimming the lights, putting them where there's not a lot of people or a lot of commotion.
Okay.
So they definitely go through a series of phases, and even before they reach us, they're in ICU and they're even receiving therapy then, because research now is showing the earlier the better.
The sooner the better.
Yes, the
Exactly.
earlier the better. So even just like Dr. Perio said, getting up to the chair, that's very important early on, and then later on they go through the process of moving through the hospital and getting to us.
Okay. And Carol, let's talk about, as a nurse too, you, I'd imagine you're following someone all the way through. Dr. Tortilla. So Dr. Tortilla isn't done soon. However, you're the one that really you and your team follows people through. What are some of the steps that a person once, and let's talk about any situation, once they're able to accomplish A, B, and C, can they consider being appropriated to take home? Does that make sense? So walking, not falling risks, all that. Can you explain some of those?
Well, we do continue to assess their progress, and since it is a team, we communicate with therapy, case management to get them appropriate resources and family help and support during the traumatic or the change in lifestyle that the patient is going to have.
Okay.
So we have all those resources available for them, and in preparation, everything starts on admission, so that we cover all our bases, and that way when discharge comes, they are confident and ready to go home.
So what are the specific things that they need to do to look at being able to go home? So let's talk about walking down the hall, or talk about some of the specific things that they have to be able to do.
They have to be able to manage stairs.
Okay.
Getting into a vehicle for discharge, or when they're able to go to doctor's appointments with the family, and family training is very important. Once family is safe to do that, they are also considered to be safe to go home if that's the plan.
Dressing themselves, using
Correct.
the restroom.
Yeah,
Those are the kind of things I'm looking
grooming,
for. Okay.
and all that.
Okay.
Activities that they were doing on their own at home, like preparing meals maybe, and if that's something that they can do, or if we have available resources for help until they're able to do it on their own.
Okay. Makes sense. So let's talk about a rehabilitation unit at this point. And let's say that there is someone who's had a stroke. And the stroke, and my goodness, there's such a wave of very severe to we're not sure if we should keep them or not. And so feel free at this point we are now diagnosed, treated, but there's some rehab to be done until we go home.
Correct.
Once the patient arrives to the rehab unit, what can they expect once they get there?
Well, they will be seen by the physician every day. We actually have support of internists as well, because these patients, especially the more severe the patient is, they tend to have medical complications throughout the course of the rehab. So it's not all smooth. I mean, there can be bumps in the road, but basically they get a thorough assessment, and every day the physician is looking into medication, appropriateness of the medications, eliminating medications that may be impeding
Right,
recovery
good point,
or
right.
the mental state, adding medications to stimulate them or address depression. We look into their bowel, their bladder, continence, things that, again, will be important to go home. We get patients with tracheostomies, with feeding tubes, so we immediately get speech therapy involved to try to offset that and eventually see if they can start eating normal food.
Okay.
Otherwise, we'll adjust. We try to make those tube feedings appropriate for home. Immediately, the rehab doctor, as soon as you see the patient, you have to start estimating how long the patient would need to be in the unit to prepare that family.
Exactly.
So
okay.
say, well, we are foreseeing about 3 weeks, 4 weeks, because then the family need to start thinking about what modifications we do home with the help of the therapists. So it's really a very complex process, but basically it is a very dynamic, ongoing process, and as you said, is a team work. But once the patient and family step in, family gets integrated in the program. So they need to start learning
Right.
what to expect, how to address this, and sometimes, for example, the patients with tube feedings, families are very impressed, and we still invite them to learn, even with the expectation that that might not be the way they'll go home, but we
Right.
need to prepare from the very beginning for the same thing. So there's a success upon transitioning home.
Exactly. And Jacqueline, let's carry that a little bit further. So when there are family members there, and let's use examples, because I feel like that's how we can walk through. So let's just say that we have a young stroke patient. This is a patient who's 55 years old. And so they have children in their 20s. They might have mom and dad around in their 70s or not. We're not sure. But so this is a middle-aged individual. Now they're in the rehab unit, and the family, whoever might be around, is coming in. What is it that you try to teach the family members at that point?
So that happens a lot, actually. So first of all, we like to ask, who they plan on, what the plan is going to be at discharge, you know, who they're going to be going home, who's going to be taking care of them, because we definitely like to especially include those people in family training, because I like to do a lot of hands-on with them. We like them to actually physically assist the patient if that's what's needed. I do a lot of demonstration. We like to simulate the home environment. So I like to recreate the home. So sometimes that may be the bed may be elevated at home, so we need to practice that in our gym. Sometimes it means they need to get into a truck. So sometimes we actually go down and practice getting in their actual vehicle with the family member.
See, and I love that. Continue on the specifics, because I think that's what people in our audience are looking for. So truck, bed, sitting in a chair but then getting up. A kitchen chair is a lot different than sitting in the chair that you'd like to watch TV in, that you're in for a couple of hours. So at this facility itself, at the unit itself, I'm assuming then you have a lot of these, trying to get across a rug if the rug is not attached to the floor. I mean, that is something that in the show I've heard over and over again, that's where a fall can happen. And it's something as simple as either taking the rug away or taping it down. So as many of those that you can give.
Yes, and we definitely go over that. And we also do a lot of outdoor walking. So just to practice walking on unlevel surfaces, how to go up and down curbs, going up and down ramps. And we also actually do community reintegration outings. So if we can practice taking our patients somewhere, I think some recently went bowling, just going to the grocery store. So we can also take the patients there and practice in those environments, somewhere something that they were doing before.
I love that. And that makes such a difference too, if you don't want to just be caged up the entire time. Like you said, getting back to living. I love the title of this program to begin with. Carol, specific services at Las Palmas Del Sol Healthcare within the unit. Again, you are the nurse in the rehab unit, and even going home, there's a lot of touch base, I'm assuming, with you. What's specific at Las Palmas Del Sol that might not be somewhere else?
We do offer respiratory therapy for patients that come in with debility due to pulmonary issues or pre-existing issues that they can be treated. We also have radiology, we have laboratory, we also have wound care, which consists of nurses that specialize in wound care treatments, anything from very superficial to deep wounds. And they also specialize in negative pressure therapy, wound vac therapy. So that's very useful.
So you just opened up that can of worms that often gets opened up in El Paso. So wound care and diabetes. And Jackie and Carol, I'm going to kind of bounce back and forth between you two because family is so important. Again, if someone is released at home, and then wound care, and this is where I'm going to ask if you can be specific again, how healed does a wound have to be in order for someone to be able to take care of the wound at home? And that's always the big question. And you're smiling too. So Dr. Tortilla, feel free to move in on that. And that's a whole issue. It could be a wound that's been there for a year. Again, with diabetes, that's not uncommon. How is that you deal with the family and how you teach the family to help dress wounds? It's an open, crazy, huge question, I know. And I'm looking at Jacqueline first.
So basically at the end when they're leaving, so they may actually go home with a wound vac.
Okay.
And it's not the same wound vac that they have when we're working with them in therapy. They get to take a portable one home. But often they're recommended to continue with wound care services at home.
Okay,
and that's
yes.
continued services. But we also do, I believe nursing also helps train the family on how to manage a wound if that's necessary. If they need to. So they do practice that as well.
So Carol, now it's necessary. What is that training?
Well,
what does it mean? What is being trained? Is it the removing of the dressing?
Correct.
When you're talking about a wound vac, so it's a vacuum that takes the
drainage.
The drainage, thank you. I was looking for the right word, exactly. So explain that to the audience.
Well, we first of all what I usually do is explain to the family members the purpose of the wound vac. Let's say it's a wound vac or any type of dressing, the purpose of it. And I kind of just go ahead and show them first how I do it and explain to them what I'm doing, what to watch out for, any signs and symptoms, or
and what would signs and symptoms be?
Like any change in the wound bed itself, any change in color, any like pus or any kind of different drainage,
swelling,
any odor,
anything
that's different from what we're seeing now. And that's why I show them this is how it looks now, so you can notice if anything is changing when you go home, and you can identify those at an early stage.
Okay.
Yeah, so I usually try to just demonstrate how I'm doing it, ask if they have any questions while they're observing, and then next time around I will go ahead and slowly integrate them into cleaning the wound and making them feel comfortable, because it's
difficult.
Very,
and that's why I wanted to be specific and explain it to the audience too. It's a very difficult thing to do because you have this idea too. It's a person that you love, and you know it's hurting when you do that, and so there's that give and take. And on that note as well, and again, we're talking about rehab with all kinds of things, and let's say it's trauma. So we've got wounds, we've got head issues, we've got neurological issues, and just a shout out to all caregivers in general, and Jackie, you're totally like nodding your head, because you guys get it, because you deal with the families all the time. When you look at trauma versus stroke. So let's go back to the strokes again. So now we have someone who's had a stroke that if they needed to be in the hospital about 2 weeks, let's say hospital 2 weeks and then go to rehab for another 2 weeks, what level of a stroke are we looking at here?
Well, for 2 weeks, that would be probably a mild stroke with an expectation of a relatively quick improvement, and that doesn't mean that the patient is completely recovered from the stroke, because that can take months. But again, our focus is functionality. I always tell the patients our objective right now is to get you solid enough,
Exactly.
steady enough on your feet, and relatively self-sufficient so you can head to the next level of rehabilitation.
Right.
Because it
And then
doesn't
there
stop
are
at the
the-
hospital.
And I should have started this too. There's the hemorrhagic stroke,
Oh,
and then
yes.
there's the ischemic stroke.
Correct.
And it's not that one is worse than the other, one is better than the other. It's just that the recovery is different.
Correct.
And I'd love for you to go into recovery from one versus the other.
Well, typically, a bleeding, what I call a bleeding stroke, tends to be more catastrophic at the beginning because, I mean, you may die from it. Of course, you can die from a massive stroke.
Right, right.
But generally, that wouldn't be the case. But it recovers quicker because as the blood is being resorbed, and you can see how the patients are improving relatively steadily. So in terms of prognosis, they tend to progress better.
Interesting. Okay.
And
and that's true
kind
with a
of
bleeding stroke because the pressure is being relieved by taking the blood out.
either,
And that's-
or again, even if they are not evacuated, but again, there's a process of that blood dispersing.
Right. And that's what our
resorbing,
bodies do.
And that's how then you can see mental faculties improving, etc.
Okay.
And again, it's not necessarily that smooth, but that's a rule of thumb. Now, an ischemic stroke, that brain has, an area has died
Right.
or close to die, so that is an area of shock. So with the bleeding, it's just the pressure that blood is exerting on the brain. But if the brain is not dead
Exactly,
underneath,
good point.
it is, you have a better prognosis. But again, with the ischemic, there's going to be a rate of improvement. The more severe is going to take the longest. Of course, within the first 6 months, in general, is our prime time when we're going to hit the patient with everything we have.
Right.
So we don't want maladaptive behaviors to happen. We don't want compensatory strategies to happen. We want to try to push and recover skills.
So when you say compensatory strategies, what does that mean?
For example, let's say the patient is weak on the left, let's say the right side, and
Okay.
you're right-handed.
Okay.
And of course, you try to do things with the
Exactly.
right, and then you can easily say the patient not use your left.
I see what you're saying.
And it's
so when you're talking about in the
easier-
beginning, reverting back
Correct.
is what the goal
Because
is.
you don't want, again, you want that area of your brain to keep stimulated. So if you are just going to teach the patient to use the left and become a lefty, you're not doing them a favor.
Right.
Immediately you're making them functional, but for their recovery, you are not doing a good service. So even if that limb is not moving optimally, you try to still ask the patient, even think
Right.
that you're using that, because you're trying to establish those connections between the brain and your body. So, I mean, it's fascinating. There are multiple
No,
things
that's
that you can
beautifully
think.
said because when you have, the stroke is blockage, there's blood not being able to get there, oxygen, and then so that part of the brain dies. And on that note, Jacqueline, I'm going to ask you, so you're working now with an ischemic stroke patient post a couple of weeks. The part of the brain that is trying to revert, trying to not regenerate, that's absolutely the wrong word, but trying to reteach the patient the motor skills. Because it's not a cognitive thing, it's more of a motor skill thing. How do you work with that? And let's go on the same idea that the right arm is not working easily anymore. And so now you're really concentrating on the right side of the body. We can integrate some speech questions in here as well. If I'm, usually it's the right side or whatever side it is. And let's just say for this exercise, it's the right side.
Okay. So depending on the level of patient, so say for example, I have a higher level patient, I'm walking them, but they still need steadying assist, I would probably attempt to use a walker, so that way I would have them use that right hand and put weight on it. So we do a lot more weight bearing on that right side, whether it be shifting towards that side when we're doing some walking training, or maybe when we're getting out of bed and I'm having them push up on that hand.
Nice.
Maybe when we're
Okay.
standing up, I'm having them use that hand to help them push up and make sure they're putting also weight through that leg. So it's just trying to balance their weight on both sides, so they're not cheating and using the opposite side to really help them. So it's helping them adapt that way.
There are other techniques that they utilize. For example, there's a concept of constraint-induced therapy. It's a little more drastic because it really requires a patient that is well motivated, because they're going to get frustrated by using a limb
The
that is
motivation is a
weak.
key.
There's
right.
also mirror therapy, which is that you are asking, you're using the reflection to cause a false illusion that the affected side is improving. So there's a lot of neat stuff that you can utilize. We are now using, in the era of technology, we have neuroprosthesis, what we call like electrical stimulation.
Right,
And
okay.
then you ask the patient to move the limb, and with the electrical stimulation, you're causing a feedback. So that limb is moving, so you're trying to reconnect those pathways.
And on average, and this is so, I loved when you were talking about the motivation. On average, is the level of motivation in association with age, in association with support system, in association with what? What have you seen? Because you're absolutely right, and I love that you hit that note, that if the patient is motivated, chances are, I mean, really the percentage, and I'm looking at both of you, is so much higher than if someone's like, oh God, physical therapy again. All right, I'll do this for an hour and then I'll just hang out. So, Carol, you're smiling, and I skipped you last time around. But since you're smiling and nodding, talk about, to people at home who may have this person in their family, who is this person in their family, how important is it to be motivated as the patient? Because we talk about the family members, but as the patient themselves.
It's very important, very, very important. Without motivation, it's very hard for them to believe that they can do it. And for me personally, I try to motivate it as much as I can, and you see that change right away in their attitude, and you see them progress. It's really awesome to see them, and it's very, very important for them to be. And I think the family support and even staff support and encouraging them and telling them that they can do it, it just makes them happy. Sometimes they're just so depressed and sad of what has happened to their ability, their functionality, that sometimes they just need that push, and it's incredible what motivation can do.
Agreed, and that's a point too. So you're looking at any time there is a big traumatic event, depression is definitely something that creeps in, and anxiety as well. So you've got the anxiousness of, oh, am I going to get better? And then you get depressed as well. So let's talk about a patient who's never had any issues with anxiety or depression. All of a sudden, again, let's just use mid-50s, this person in their mid-50s. Now all of a sudden it's like, oh, what's the point? Do you treat that with medication? Do you treat that with cognitive behavior? Do you treat that with, Carol and Jacqueline rah-rahing? Is it a combination of all? Because I'd imagine that happens 70, 80, 90% of the time.
Yeah. Well, typically I wouldn't like to jump into medication,
Agreed.
like adding medications. I mean, we really want to help that patient create a good emotional base. Because this process of rehabilitation is not going to stop at the hospital.
Right.
It's going to be a long curve, especially for the more catastrophic injuries. So that patient really needs to develop a strong core. So we, of course, we're going to start with tender, loving care. Sometimes we need, and I'm usually the one with the with the whip.
Put the stick on
they
it.
are like, yeah, and I'm like, ma'am, sir, yes,
Right.
time is ticking, so we really have to start moving a little faster.
Right, exactly.
But if the depression or anxiety or whatever it could be is really pervasive and really getting in the way of them participating, I'm going to jump into medication
Somehow
management.
address it, yeah.
The more I would expect the patient to have a long-term impairment, I might still be adding the medication, because as much as you see them coming along and they get more animated, but then the next phase is going to be facing struggles in the community. And without the support of your therapist necessarily.
Right, exactly.
So that sets a new
Like a set point, even.
Correct, of hurdles, new expectations, frictions between family members or what have you. So, you know, I'm trying to foresee the need of that medication long term and educate the patient. Sometimes they just are very resistant to the medication because they don't want the cliche.
Right.
And I just want to tell them that we are managing the chemistry of the brain, which is true.
Beautifully said. We're managing the chemistry of the brain.
And
right.
this is not necessarily going to be long term. And as the patient progresses, we're going to taper that off.
Right. Nicely said. I have a question here, like a pre-question from earlier. It was directed at Carol, but I'm just going to throw this out at anybody. So, Carol, we're talking about the intake procedure. We were talking about just getting people there. To be very, very clear on what a person's past history has been, how important is that when you're assessing a patient and knowing what the treatment's going to be going forward? Because again, as a nurse, you're dealing with this long term. And this is one of those times you can say to the audience, hey, remember that depressive episode you had when you were 22? You got to let me know that if you're prone to this, it's important. So talk about how important that is.
It's very important to be very transparent in the medical history. It allows us to not only provide optimal care for that patient, but also identify risk factors for any potential problems that may happen. And also, family history is a big issue. We need to know family history of medical illnesses because they're more prone to certain things, and that way we can, you know, tailor education for the patient so that when they leave, they're able to make lifestyle changes that will be appropriate for them.
And how often are the other family members involved in that process? And I got a smile here from Dr. Padilla because there are certain things like, oh, I don't want them to know that I fell 5 times last year, and I don't want them to know this, and I don't want them to know that, because there is a certain pride to being healthy, especially as we age. And so the reason I ask this is that I think it's so easy just to blow things off. And in a situation that's neurological, I feel like that's when you can't do that, because you really have to look at history. And I don't know if Dr. Padilla, you have some ideas or some case studies of where a history was missed just because you didn't get the information, or let's just say a person's not cognizant when they come into the hospital, and how having history would be helpful.
Well, of course, is very important, but you know, we want to engage with the patient first and create that rapport that is going to allow us to get that history. We get what we have,
right? Exactly.
What the patient wants to disclose, and we also have to respect their wishes. I mean, and we are, you know, we have that kind of limitation where we have to respect everybody's privacy, etc. We're going to push and we're going to try to go around. We have case management. We try, but again, establishing a more personal bonding so the patient starts opening and providing that history underneath. And sometimes they come like they have the very best support, and it's the contrary. You know, the patient is telling you, oh, all these people are going to help me. And as we're getting closer to go home and we're trying to get that family engaged, you start seeing that resistance. And we also have to address that and the families and offer a lot of support. Mind you, sometimes we don't have a psychologist to help us. So we are not only dealing with medical, nursing, or therapy. We become psychologists,
you become
psychiatrists.
The human aspect of it all,
everything. So these patients actually live like they are family members. They come often to visit, to thank us. Sometimes we actually change family dynamics. And again, it is a give and take. It is what the patient is able to disclose or give or take. But we try to establish that bond. Sometimes with the doctors, it's like, hello, bye, you're stable, take the medication. So this is a completely different vibe.
And I think that's so good. And I love what Jacqueline said earlier, too, about taking them, again, to the bowling alley, to grocery shopping. How is that arranged? So if they're in the rehabilitation unit and there's a certain day that you're going to take, okay, I think that you know, Mrs. Jones is now able to go to the grocery store. Do you arrange that? Does she arrange that with a person from home? How does that physically work when you take them out to the community?
So the hospital does provide transportation, and we decide whether they need to go in a wheelchair and if there needs to be a wheelchair lift. But we also have the therapists go on the outing, as well as our recreational therapist, who is involved with a lot of our social activities there at the hospital and the rehab as well. And then we take them on that outing, and we are doing activities there to challenge them and kind of see how they are, what they're doing in the community, and maybe if there's something we can work on with them there.
And it's something as simple as reaching for something a little bit higher than your level, and in a wheelchair, that's a whole different way to navigate than when you were standing. No, that's lovely how you do that. What are some outside factors? And Dr. Padilla, I'll bring this first to you, and then I'm going to throw that to Carol too, because Carol, again, you see this on the outside, but other than family, maybe let's talk about the house being outfitted differently, if they are going to be either forever in a wheelchair, or if we know that this person's going to be in a wheelchair for the next several months. What are some of the outside obstacles that can help out with rehabilitation?
Well, the most basic will be some basic modifications that we can ask the family to do ahead of the game, like create a ramp or buy a portable ramp. Of course, getting the agencies, vendors to get equipment, but we can go more so trying to find appropriate vehicles, like with hand controls, environmental control units that you can activate, like switch or anything.
I gotcha. Okay.
With your voice or just you know, with air. So it's a very...
Yeah, it's in, the reason I bring that up too is that it seems to be so complex and ongoing. And again, Carol, that's where I was thinking about you. I mean, it's an ongoing thing. And let's say it's a year and a half after the stroke now. And what you, Dr. Padilla, was talking about earlier, you want to revert back to what it was as much as possible. And if your left arm is still overpowering the right arm, you still want to continue working that right arm. So let's talk a year and a half into it now. Now we have a house that's set up for a wheelchair, bigger walkways, but we also don't want to impede the idea of them continuing. And Jacqueline, feel free to jump in. You're good at nodding. I love the nods. That always helps. So a year and a half out, what have you seen with different patients? I'll go to Carol first, and then I'll go to Jacqueline.
In regards to them progressing?
Exactly. Progressing, and what can the outside obstacles be to where like, oh, okay, you know what, I'm good enough. And how do we get them not to say, I'm good enough? You know, and that's, and you're cute because you're smiling and nodding too, because I know people who are at that point. That you know what, this is good enough. It's too much work to get to where I was before, to keep trying. And that's a mental issue, that's a physical issue, that's a support issue. I feel like it's a big picture issue when we're looking at that.
Right. Well, sometimes we have patients that do come back and visit us and tell us how things are going at home, and we just try to encourage them to continue down the path that they are and continue going to therapy and doing their exercises and just motivating them for.
And do they ever come back to get more physical therapy in the hospital unit?
I guess that's where I play a role, because typically the rehabilitation doctor is going to be one of those chronic doctors,
right,
along with the internists. And typically I would like to see that patient at the office and follow. I mean, I have had stroke patients for many years. It becomes family.
Right, yeah.
Because then no other doctor is going to keep looking at the areas of impairment or physical disability, mental disability, whatever it is. Social integration, that's the role of the rehab doctor. That's where I'm saying we are underutilized and underestimated. That's the role of the rehab doctor. Carrying this patient, you are now out of the hospital, now we are going back to work.
Gotcha.
How can I go back to work with the right side? Yes, you can.
Okay.
There are modifications that need to happen. That's the role of the rehab doctor, along with the therapist. Then I can say, hey, Jackie, I need to send you back the patient. And I like the concept of the tune-ups in rehab. that's where,
A tune-up in rehab. That's exact. Yeah. Okay. Perfect.
and that's what the rehab doctor identifies.
Okay.
That's why it's very important that the rehabilitation specialist remains on the case, because it doesn't stop. 6 months, the therapy may end up, again, because of health care.
Right, right.
You have 2 more months of outpatient therapy.
Yeah.
Bye-bye.
Oh, that makes me so
So
mad.
you see
Yeah.
the rehab doctor. Okay, 6 months. Let's try that therapy
Right.
through other ways. Or let's try very focused therapy intervention. Again.
And when you're talking about tune-ups, give me example of what that might be. So this is somebody that, let's say they had their 6 months because that's what insurance paid. Now we're 6 months and 2 weeks out, and they're trying everything they can at home on their own with support. But there's just support where, the family members have to go back to work or
Correct.
whatever. So when you're talking about a tune-up, tell me just some examples of what you've seen in the past.
Let's take that patient with the left side.
Gotcha.
We got them to at least grasp objects, maybe brush, hair, but then family goes, and then they're now watching TV, maybe
Right.
eating a little too much, and then getting heavier. It's a little more cumbersome to go to the YMCA to do the aqua therapy, whatever. So
Exactly, yeah.
then you stop using that limb, and then you start getting stiffer, and you go see the rehab doctor, and hey, what happened
What
here?
happened here? Yeah.
Oh, well. So then
Yeah.
you start looking into the emotional, everything else, diet, medications. Maybe I haven't seen my doctor, and I want you to refill that medication. Hey,
I
what
haven't
is
done
happening?
that.
You're not following with
Exactly.
your doctor. But then I
Yeah.
said, okay, let's just send you to the occupational therapist.
Right, right.
To do some
and
good
there's something that's
stretches.
called cause fatigue or illness fatigue.
Correct.
There's a certain point, it's like, God, this is 3 months now, 4 months. To the person that it's happening to, this is a minute. But to the person that's taking care of the situation, you're right. It's like, oh, gosh, I'm tired of this.
Correct.
So I'm so glad that you brought that up. We are kind of at a 10, 12-minute mark in our show. So what I want to do is stop questions from here and think about what it is that we haven't discussed yet, or something maybe we've touched base on that you really would like to get across to the audience before we go back to questions from here. And I can start anywhere. You're already nodding, Dr. Padilla, so
Yes.
I'm gonna go to you. And again, this could be something that we haven't talked about yet, but you'd really like to bring up because you think it's important.
Well, few points, or maybe one point. Most important is that concept, even within the hospital, that a patient is so severely affected that they are not able to go to the rehabilitation unit.
That they need to get that out of their head.
Correct.
Right? Is that what you're saying?
That every patient
Okay.
deserves that chance, no matter how severe. There's a big tendency, unfortunately, here in El Paso, and I have been in many other states, where patients that should receive that care go to nursing homes right from the get-go.
And so, in your opinion, or what you've seen, is that from the support system side? Is that from the medical side? Is that from the patient side? Is it just a matter of giving up? What is it that you attribute that to?
I guess, again, it's a lack of understanding of the specialty.
Okay.
And I don't want it, it's not all about me.
No, but it needs to be talked about.
There's therapy in the ICU, there's therapy in the acute side of the hospital, but that concept that, no, we can get this patient at this level in an aggressive therapy environment to try to, again, mitigate as much as possible, or even try to stimulate that patient to be able to move on to another level of therapy, rather than just go to a lower level.
And just accepting
Whatever
it.
happens, happens.
Right. I want you to be my doctor if that happens to me. I don't want someone just to give up on me.
Because
really, I mean,
everything
it matters.
we do is function.
Yes, exactly. And you too, okay? If something goes down with me, it's like, I'm gonna get her, put that foot down. No, but it matters so incredibly much, because again, all of us have seen it. We all have moms and dads and grandparents and people that we know that there's a certain point, and we can probably name them in our heads, that person gave up way too early. And now that person's either no longer around, or a shut-in, or You know, and I'm 52. I say that often on the show what my age is, and I think, and I've got loads of time, but it does concern me of when is it like, you've lived your life, we're done, let's go look over here. So on that note, thank you for doing the specialty that you are doing. What made you, and this is just a curiosity level for me and the human part of you, what made you want to do this in your life? Because this is really the human part of doctoring.
Well, I was actually a volleyball player, so I wanted to do something related to sports medicine.
Okay.
But when I was a medical student, I got an elective cutting brains.
Oh my God.
And that
yeah,
fascinated
I got
me.
cutting brains.
But then really, when I saw a patient with cerebral palsy during one of my rotations, and how I didn't see anything happening for that patient after just the treatment for the medical ailment. It is, we are treated, you go home. And you see these young patients trying to do whatever, even with their limitations, and nobody's there
to help
them or be an advocate. And of course, during the course of my training, then I got with a mentor in physical medicine and rehab.
Nice. Okay.
The PMNR is no longer a term that we like because it's not only physical.
I see. Yeah, it's
It's too
everything.
broad
It's, right.
to be encased on the physical medicine concept. But that was basically what turned around my thinking.
And I loved what both Jacqueline and Carol were talking about. It is the motivation. If you've got someone who's highly motivated, it often requires an outside force to help that happen. Because alone, it's very difficult. I mean, no man's an island, right? It's hard to do anything alone. And so we're starting here with you all and then carrying that through. Jackie, on your note, is there something that we haven't talked about yet that you'd like to talk about?
I just wanted to reiterate how important I think the inpatient rehab program is. I mean, we do intensive rehab with these patients, and a lot of times they come to us with medical complexities, but we have a whole interdisciplinary team. You know, we have our physicians, we have our nursing staff, we have our therapist, and we all work together to help get this patient back to the community. And that can include, you know, like I said, the reintegration outings. We do home evaluations. We go to the patient's homes.
Talk about that. I'm glad that you brought that up. Yes.
We go to the patient's homes and we measure doorways. We take the patients and we make sure that they can function in their own home environment. So if there are any modifications that we need to suggest, that's when we can do it.
And we can talk about, and I'm just going back to programs in the past, that there might be cords in the way. You know, if there's a lamp that usually sits on this table and that cord's just kind of a little bit in the way, maybe you can put the lamp somewhere else. We talked a little bit about rugs, end tables that might not be in the right place anymore. So I love that you all go out and do that, because that makes all the difference once a person gets in their home. Again, you don't realize what the limitations are until you get there. Right. So, no, I appreciate that very much. Carol, how about you?
Well, I just hope that the viewers watching really get a picture of what inpatient therapy really is all about, and the intensity of the therapy and how it can benefit family members in the community. So I think it's not known very much about inpatient and the valuable resource that it plays in making the patients go back to the community.
So I'm going to ask both of you a question. If you don't have an answer, you don't have an answer. But a lot of times people think about insurance and, oh my gosh, what's this going to cost me? I would love for you, if you have a phone number, if not, maybe somebody can throw it out or we can Google it really quick. But is there a person in the team that checks with insurances and say, you know what, your insurance will cover A, B, and C, your insurance won't cover this? Because you were talking about that earlier too a little bit. And if we can give out some information on that, and as we're looking for that, the question here from the audience has something to do with this here. How can someone access a rehab doctor in El Paso? So maybe this is a person who has been released, that might have some issues, that is no longer affiliated with a specific clinic or a hospital. Are there any doctors that are affiliated with public health care, or are there only doctors who work in private practice? Actually, Dr. Padilla, that's going to be a loaded question. Do you have any desire to answer that? I mean, it's huge. So how does someone access a rehab doctor if it doesn't stem from a hospital visit to begin with. Does that make sense? How I'm
Yes.
explaining? Okay.
Well, the medical community of El Paso is quite small. So the physiatrists or rehab doctors in the area have a very good rapport with all other specialists. So I will think that at least internists, surgeons abroad, they know those doctors that are in the practice.
Okay.
And as easy as using Google, that should have an updated list of providers, because there are several providers, as I said. With counting me, there are about 7.
That's a small number. So I think that's such an important question to ask of how they can, and you said, in Dr. Google, you're right. If you can stay away the things that say add on there first and really try to look
Correct.
for a list.
But there's a good list.
Yeah, there is a pretty good list,
Yes.
I agree. So either one of you, might you have an email address or a website you can throw out there? If not, I can tell the audience to search engine it. I know we have a couple of people on our audience. I don't know if they were from your team or not, but
If they can,
so just call the hospital. So I guess Las
they can
Palmas Del Sol Healthcare.com. If not, just search engine it and then try to figure out from there if there is a telephone number or a place that you can call if it wasn't, again, associated from an initial emergency visit. And most of them are, without question. It's just nice. I'd like to respect some of the questions that come in. Okay, and that's the good point too, is depending on what your insurance company is, call that insurance company, and then from there will be a list of providers and where and when they can get that information. I wanted to say again, we have 2 different places that you can watch this episode again. One is at kcostv.org. And from there, you can go to watch and the programs and then find the local programs, because a lot of times we'll speak so fast and give out so much information that we miss it. So there's 2 different places you can go to. The other one is, again, the El Paso County Medical Society website, and that is EPCMS. Just think of the acronym El Paso County Medical Society website.com, and they have that link on there as well. And for Facebook users, often if you put in the KCOS search bar, sorry, we have a fly in the studio. This usually will come up for several days after that, and then with that, there are several episodes that we have as well. So Dr. Padilla, again, is the one and only in the region neurorehabilitation specialist, which means, again, taking that practice one step further and looking at the long haul of what's coming. And that's so incredibly important. So again, I want to thank you. And if somebody that I know is in this situation, I want to have that doctor by my side. We also have Jacqueline Rincon, who is a physical therapist, and again at Las Palmas Del Sol Healthcare, and then Carol Cuss, who is a rehabilitation nurse and a person that really does the rah-rah and cheerleading with people that are coming up. And that makes all the difference in the world. Yes, and again, I want to say thank you to our 2 lovely Paul L. Foster School of Medicine. I don't know if they're on the phone right now. They might be on the phone. But Erin Pines and Heather Jones are here I want to say that you're here most months. But this month we had 2 different shows, and often there are so many questions that they have coming their way. Thank you so much for evening. Thank you so much for watching, and good evening. I'm Catherine Bird. Good night.